Bismillahirrahmanirrahim. Our project will talk about a new drug, monoclonal targeted therapy. It's called Tezepelumab. This drug is for asthma. But before we discuss some information about this drug, we're gonna dive into some details, basic details, the introduction of asthma. First of all, asthma, one of the major causes of asthma is genetic susceptibility. And according to genetic susceptibility, there is two types of asthma, the T2 high asthma and T2 low asthma. T2 high asthma, the gene that is responsible for it is the Th2. And in this type, eosinophils cells will be increased, and other cytokines like interleukin 33, 25, 13, 5, and others. And this type, it will cause airway inflammation and hyperresponsiveness, and the type of inflammation will be allergic inflammation. That's why it's called high T2 high asthma. Type 2 inflammation are the allergic inflammations. On the other hand, the second type with the low asthma, the gene is responsible in it is Th1 and Th17. Neutrophils rather than eosinophils will be increased, and other cytokines like interleukin 17, TNF alpha, interleukin 1b, and others. And this time also will be an increase of the airway inflammation, airway hyperresponsiveness, but this type is resistance, less responsiveness for steroid, but no allergic reaction or inflammation will occur. That's why it's called low. And one information that I missed, that T2 high asthma is very responsiveness to steroid. This type is very responsiveness for steroids. There are other types of asthma phenotypes, other causes that is not genetic susceptibility, like aspirin-induced, smoking-induced, asthma in elderly, obesity, and maybe T2 high and T2 low occur at the same time in one category, at the same time combined. The two of the three genes will be there. Okay. Here we see there is many triggers like pollutants, smoke, bacteria, viruses, and other external stimuli that will trigger the cytokines, especially the key cytokine, which is called the TSLP, thymic stromal lymphopoietin, the link between the triggers and the other cytokines. So when this type of cytokine is activated, it will produce it will induce the production of other cytokines that cause airway inflammation, like interleukin 4, interleukin 5, as we see here. Interleukin 4 trigger the immune globulin E, which cause allergic inflammation, and interleukin 5, which trigger the eosinophils and cause eosinophils inflammation. And maybe both occur at the same time, as we see there. Allergic and eosinophils, both inflammation occurs. There is two hallmarks of asthma: airway inflammation, as we talked now, and the other one is airway hyperresponsiveness, which is T2 independent effect caused by the mast cells. And this type is not inflammation, but it is airway narrowing, make it more sensitive, more responsive for the triggers. That's why it causes asthma. So yeah. So because TSLP is the key here, the key cytokine. So our drug that we mentioned before, the Tezepelumab or the Tezepelumab will trigger, will target the TSLP, the key, blocking it to reduce the symptoms and inflammation, making this drug effective in both types of asthma, the high, the T2 high, and the T2 low, because the TSLP have activity in both types of asthma. It induces the airway inflammation and hyperresponsiveness in both of them, but in different way. In the low, by in neutrophilic inflammation, and in the high by the eosinophils and the allergic inflammation. So in phase 3, this phase 3 clinical trial was conducted to assess the safety and effectiveness of this drug in treating severe uncontrolled asthma in adults and adolescents using a variety of primary and secondary endpoints. So this helped to solve the issues we are facing with conventional biological agents used for severe uncontrolled asthma, as current biologic agents are unsuitable for many patients with severe asthma, particularly with non-allergic, non-eosinophilic phenotypes, the low one, the T2 low asthma. As we mentioned before, the conventional biologic doesn't work, for this type of asthma. So to prove such significance of this drug, the study relied on variety of endpoints and categories to give the robust results that developed the treatment guideline. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Mustafa Naji. I'm senior PharmD student in University of Baghdad College of Pharmacy. Now I will keep talking about our clinical trial. Our study was a multi-center study. This means it was included in different countries around the world, and in each country in different centers, like hospitals or respiratory clinics. This quality gave our study a good point of strength regarding its inclusion of data of the response to the drug for patients of different races and from different regions around the world. Here we can see the study design of our clinical trial. Around 2,420 patients were screened to join the clinical study. Only 1,061 patients were actually included because of the inclusion and exclusion criteria. The criteria was mentioned before in the study protocol and the study appendix. It includes some conditions regarding the usage of inhaled corticosteroids, the usage of bronchodilators, short-acting and long-acting bronchodilators, previous exacerbations and hospitalizations, and it excludes some patients with certain comorbidities like cancer patients, like heart disease, example, ischemic heart disease or heart failure. It also excludes pregnant women and other conditions. The study, among those 1,061 patients, around 80 adolescents aged from 12 to 17 were included. So our clinical study include data of the drug response for patients from both adults and adolescents. Those 1,061 patients were randomly assigned in 1-to-1 ratio to the study groups, the placebo group and the drug group. The clinical outcomes of our study was measured based on different set of endpoints, primary endpoints and secondary endpoints. The primary endpoints was the annualized rate of asthma exacerbations, means the events of exacerbations per patient in a year, over 52-week treatment period in the overall population. This endpoint was measured in patients who have blood eosinophil count of less than 300 cells per microliter. It was also measured for patients who have blood eosinophil count above 300 cells per microliter. Because in each group of our study, patients who were included have different ranges of baseline blood eosinophil count, so we can study the effect of the drug on different kind or different type of patients with eosinophil counts, who are below 300, who are above 300, also who are below 100. Key secondary endpoints include data of different questionnaires or scores, also different biomarkers. We took before the study baseline count of pre-bronchodilator FEV1, also the eosinophil count, also fraction of expired nitric oxide. Also, we took asthma control questionnaire 6, asthma quality of life questionnaire for patients to 12 years of age or older, weekly mean asthma symptom diary, and also secondary endpoints include exacerbations associated with hospitalizations and emergency department visit, and the change in baseline to week 52 and biomarkers of type 2 inflammatory cytokines. Regarding randomization and blinding, the study, as we mentioned before, was randomized, double-blind and controlled. Double-blinded, so both the patient and the researcher or physician were not aware which patient is taking placebo, which patient is taking the drug. Regarding randomization, actually the study paper was not didn't include all the details regarding the randomization and blinding. Only some data were included. This trial is randomized in parallel group 1-to-1 ratio to either Tezepelumab or placebo. The study will also aim to randomize a similar percentage of subjects with the eosinophil below 300 per microliter, above or equal 300. In addition, a reasonable number of subjects is expected to be randomized with below 150 eosinophil per microliter and above 450 eosinophil per microliter. We can see in each group of placebo and of drug groups equal numbers of patients with different ranges of eosinophil counts were included and randomly assigned. Regarding the blinding, the study was double-blinded, as we mentioned before, but there were independent committees were included and provided with unblinded and blinded data for participant safety concerns, such as the independent adjunction committee to evaluate any major cardiac adverse events, malignancies, urgent care visit, and hospitalizations, as well as all deaths that occur during the course to evaluate whether any such event is due to the worsening of asthma. Also, a data safety monitoring board will periodically review an unblinded safety summary, tables, and listings, and evaluate for subject safety and make appropriate recommendations. type of sampling. The randomly selected groups were then stratified with stratified sampling method into equal groups based on several criteria. Both of the placebo group and the drug group were stratified according to several criteria, including geographic region, age, and gender. Also, before the study was started, we checked the trial population to ensure that patients were across three characteristics. Approximately 20% of patients were to have received stable medium inhaled corticosteroids in the previous 3 months. Approximately 40% were to have had at least 3 exacerbations in the previous 12 months, and approximately 50% were to have blood eosinophil count of at least 300 cells per microliter. Also, patients were also stratified according to the fraction of expired nitric oxide at baseline and allergic status at the baseline. After 52 weeks period of the study, we checked for the results for the primary and secondary endpoints, and we found the following. For primary endpoints, patients with blood eosinophil equal or above 300 cells per microliter, Tezepelumab treatment resulted in annualized rate of asthma exacerbation of 0.93 as compared with 2.1 in the placebo group, rate ratio of 0.44, and we can see p-value is less than alpha less than 0.001, which means there is a significant difference between the placebo and the drug, Tezepelumab. For patients with blood eosinophil less than 300 cells per microliter, the annualized rate of asthma exacerbation was 1.02 in the Tezepelumab group and 1.73 in the placebo group, rate ratio of 0.59, and p-value is less than alpha less than 0.001. Also mean that there is a significant difference between Tezepelumab and the placebo group. For secondary endpoints, after 52 weeks, the change in baseline in pre-bronchodilator at EV1 was 0.23 liters in Tezepelumab group and 0.09 liters in placebo group, which means that the change was higher in the Tezepelumab group, difference of 0.13 liters, and P was below or less than 0.001. The treatment effect was observed as early as week 2 and was sustained throughout the treatment period. Also, the change from baseline in ACQ-6 score was minus 1.55 for Tezepelumab and minus 1.22 for placebo, P less than 0.01. In the AQ-LQ score, the change from baseline was 1.49 for Tezepelumab and 1.15 for placebo. Also, P below or less than 0.001, which means there is a significant difference between Tezepelumab and placebo group.
Hello everyone, my name is Mohammed Adnan and I'm a senior PharmD student at College of Pharmacy, University of Baghdad, and I will be continuing what my colleague Mustafa Ali has started. Regarding secondary endpoint results, Tezepelumab and placebo show no significant difference with ASD score, reflecting daytime severity, daytime frequency, and nighttime severity. So the frequencies and types of adverse events did not differ meaningfully between Tezepelumab and the placebo group. So what is ASD score? ASD score is a patient-reported outcome regarding the occurrence of asthma symptoms throughout the day and its effect on daily activities and sleep. So Tezepelumab didn't result in significant difference with the severity and frequency of these symptoms. But other improvements were observed from the first post-baseline assessment and were sustained throughout the treatment period. The rate of exacerbations that were associated with hospitalization or an emergency department visit over a period of 52 weeks was 0.06 with Tezepelumab and 0.28 with placebo. So Tezepelumab resulted in significant lower hospitalization or emergency department visit. Reductions from baseline in blood eosinophil counts and FeNO levels in patients who received Tezepelumab were observed at week 2 and were sustained throughout the treatment period. FeNO levels are nitric oxide levels in the breath of an asthmatic patient, and nitric oxide is a biomarker for the inflammation in the lung, as well as the blood eosinophil count. So Tezepelumab resulted in reduction from the baseline in these values. Serum total IgE levels gradually decreased over a period of 52 weeks in the Tezepelumab group. And now we will be talking about an important aspect of any medication, and that its safety. A total of 77% of the patients in the Tezepelumab group and 80% of those in the placebo group reported an adverse events, and 9.8% and 13.7% reported a serious adverse event respectively. So we could say that Tezepelumab resulted in lower adverse events than the placebo group. The most common adverse events were nasopharyngitis, upper respiratory tract infection, headache, and asthma, which were more frequently observed in the placebo group than in the Tezepelumab group. The incidence of severe infections did not differ between the trial groups, nor did the incidence of cancer. Injection site reactions occurred in 3.6% of the patients in the Tezepelumab group and in 2.6% of those in the placebo group. So Tezepelumab resulted in lower adverse events, but it resulted in more injection site reaction than the placebo. The percentage of patients who discontinued the trial regimen was 6.8% in the Tezepelumab group and 10.7% in the placebo group. The percentage of patients who discontinued owing to adverse events was 2.1% in the Tezepelumab group and 3.6% in the placebo group. So this results in the patients who discontinued due to placebo more than the patients who discontinued due to Tezepelumab medicine. Now we will be talking about conclusion and recommendations of this study. Tezepelumab significantly reduced exacerbations in adults and adolescents with severe uncontrolled asthma, including those with low blood eosinophil counts. So Tezepelumab will be more effective in those with low blood eosinophil counts and improved lung function, asthma control, and health-related quality of life. It is a safe and effective treatment that works on inhibiting TSLP, which will suppress multiple inflammatory pathways as it have broader physiological effect than targeting individual T2 cytokines. So it will be recommended for severe uncontrolled asthma as it shows better outcomes from the first weeks of use. Lastly, we will be talking about our comments and critique of this study. This clinical study is excellent. It gave us a thorough image about the drug and disease background, the aim and results. It has great points of strength regarding its sampling and sorting system and follow-up process. Also, the inclusion of participants from different countries and regions around the world and from different races, genders, and ages gave it comprehensive result that could be applicable for different countries. In Iraq, it was possible and beneficial to be a part of such a trial among the other nations that were included, such as the Saudi Arabia. It will enrich the study with more data about the drug in the Middle East region. On the other hand, it's quite hard for the Iraqi researchers to conduct such trial on their own, as they will need a great deal of funding, which will be very costly, especially with such biological drug, which is $4,160 per 210 milligrams per ml injection. Thank you all for listening.